And welcome to the Dr. Bob Show. We all worry about crushing chest pain. Is it a heart attack? We'll be spending most of this show talking about chest pain and what can mimic a heart attack, or is it a heart attack? Because if you're having a heart attack, you've got 90 minutes to get to the emergency room so they can reestablish blood flow. This may be the most important Dr. Bob Show that you've watched. My guest is Dr. Phil Jones. Dr. Jones is a board-certified pulmonary lung specialist and a board-certified allergy and immunologist. He'll be answering our questions. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about an abdominal aortic aneurysm. And we'll be talking about breast cancer. What are some of the newer things in breast cancer? We're getting better, but we need to even get more better. A lot of information for you. You'll want to stay tuned. We're talking with Dr. Phil Jones, board certified in pulmonary lung disease and board certified in allergy and immunology. And we're talking about chest pain. There's so many different types. Phil, welcome to the Dr. Bob Show.
Thank you for having me. Glad to be here.
So when you think of chest pain, what do you think of?
Gosh, there's so many things to think about. Think about all the things that are in the chest. We've got the heart. We've got the sac.
Where's the heart located?
Right here in the middle. It's called the mediastinum.
Okay, the mediastinum, the heart's there. Yeah. A little bit over on the left side?
A little bit over on the left side.
And then there's a sac around it. What'd you call that?
Pericardium, or the pericardial sac. Pain can come from either one of those.
Uh-oh. And then what other things can cause chest pain?
The aorta that comes off that takes blood to our feet, to our head. Very important organ. Then we have the lungs. The lining of the lungs, the ribs, the muscle between the ribs, the skin.
All of those can cause chest pain?
Yes, and if that's not tricky enough, sometimes organs in the abdomen like to refer pain to the chest. So it's
like what?
The pancreas, the gallbladder, reflux.
And they can cause pain in the chest that would mimic, or somebody might think they're having a heart attack.
Absolutely.
So let's start. Tell me first, what is a typical heart attack pain like, so we can start from the beginning?
Well, the classic, and this is we have typical, we have atypical presentations. There's a lot. Atypical may be more common than we thought, especially in the elderly, the female patients, diabetics. But the classic acute coronary pain is a squeezing, a pressure, radiates up into the neck, the jaw, into the arm. But as a cardiologist once told me in my training, he said, any pain within 6 foot of the heart can be the heart.
So you've got to think of lots of different things that can cause that.
You really have to think when you're looking at chest pain, because some of these conditions are life-threatening, and if you miss them or lead to a delay in diagnosis, bad outcomes for your patients. You've really got to be on top of your game.
Now, if somebody's having a pressure chest pain, a squeezing pain, and it is due to a heart attack, why is it important to get to the emergency room quickly?
You have got to reopen that blockage. So with an acute coronary syndrome, we have an atherosclerotic plaque.
That's hardening of the artery plaque.
Hardening of the artery in the coronary artery. If that plaque ruptures, we have platelets. They adhere, they aggregate, and then they cause a thrombus formation.
So that blocks the blood flow, and
Correct.
that causes the chest pain.
Yes.
So let's talk about the reason you go to the emergency room quickly, they can get rid of that thrombus. Let's talk about some other chest pains that are in the same area. You mentioned several. You pick one and we'll talk about that.
Well, I think another one to be very aware of is aortic dissection.
So the aorta is the big blood vessel that comes out of the heart?
Correct.
When you say dissection, what do you mean?
Dissection. So this is a little tear in the lining of the blood vessel. It's called the intima. Blood and it's that when the heart squeezes, all that pressure goes into the aorta. So this is a high pressure system. So we get a little tear, blood dissects into that between it and the middle layer called the media, and each beat of that heart, that blood dissects further and further.
Whoa, that sounds like that life-threatening.
Life-threatening.
What are the symptoms?
It is, patients typically describe a ripping, tearing, acute onset pain.
So they'll have a tearing chest pain, typically. Yes. Again, anything within 6 feet can be the heart.
So, yes.
So pressure pain for the heart, tearing sensation, abdominal aortic, thoracic aortic dissection. Yes. So name me another one.
Yeah, to follow up on that, Dr. Bob, as that dissects through, there's branches off the aorta. Well, one of those is the carotid. So as it dissects, it can block that artery. So you might come in presenting with stroke-like symptoms, but really it was the dissection that led to that.
Whoa.
So it's very, very tricky. It's one you really have to, and a lot of those patients never even make it to the emergency room. They die before they make it there.
So mention a little bit about reflux disease causing chest pain, or about a blood clot going to the lungs that mimics chest pain. Let's talk about the blood clot, pulmonary, what do you call it,
pulmonary embolism. And it's probably pretty darn common, and there are certain reasons we get that. Sometimes you just don't know. Sometimes it's a long trip. I flew across the country, or I was in bed sick for days at a time.
So why does that cause a blood clot that would go to the lungs?
Well, those blood clots tend to form in our legs or the pelvis, and that immobility, inflammation, these kind of things lead to this predisposition. We see it in smokers, we see it in pregnancy, we see it in obstructive sleep apnea syndrome. There's some people who have inherited forms of thrombophilia or predisposition to blood clots.
Somebody has knee injury, and below the knee injury you get a blood clot there.
Yeah.
So if the blood clot goes up to the lungs, especially a big one, what's the symptoms?
Yeah, well, it can be as simple as, hey, I feel a little short of breath. Maybe it's pain. Maybe it's a large pulmonary embolus that occludes the pulmonary artery or the branch point in the pulmonary. We call that a saddle embolus.
So that's a big bad one.
That's a big one. There's no, something's wrong in that situation.
What does it feel like? What does the patient tell you if they've got a saddle embolus, a big one, right in the right behind the heart?
Some of those people, there can be pain with that, but a lot of times it's not enough blood flow in or out, so we drop our cardiac output, lightheaded, dizzy, pain when we take a deep breath, hemoptysis.
Coughing up blood?
Coughing up blood, absolutely.
So it can mimic a heart attack. Tell me about reflux disease. How can the esophagus cause somebody to have chest pain?
The tricky part about the chest, the neural pathway, this afferent pathway that takes the message back to the brain.
The neural pathway, what does that mean?
That's the part of our nervous system that transmits that pain back to our brain.
And the pathway it travels.
Yes.
Okay.
And it comes back up. But the problem is they share it. The heart, the esophagus. And so these symptoms often overlap. So you can have reflux and it feels like the worst heart attack ever. And you say, well, with reflux, maybe it comes up the chest, maybe I belch with that. The problem is with inferior MI, myocardial infarction, you can do the same thing. So it's very, very challenging. Oh. And we're prone to attribute that, that's just reflux. Well, I assume coronary syndrome until you prove otherwise.
And if it's within 6 feet of the heart,
yes,
like reflux can be. But the reflux can cause the same pain right in the middle of the chest. That's difficult. It really hurts the patient.
Very challenging.
How long does that pain last usually?
That pain, it can come and go. And in the emergency room, we'll give what's called a GI cocktail. You swallow it, and I feel better relatively quickly. Sometimes that gives you some clues, but reflux can last for minutes to hours, depending on the severity of the reflux.
The little sac around the heart, you called it the
pericardial sac.
Can that cause chest pain?
Yes, unfortunately. Yet another thing we have to think about.
That's what we're going to be talking about when we come back. The pericardium is one. We've got about 4 or 5 or 105 other things that can cause chest pain that might make you think you have a heart attack. But if you're having that chest pain, you have to think heart attack first. You have to get the emergency room. We'll talk about some other factors. You're going to want to stay tuned to this. We're talking with Dr. Phil Jones, board certified pulmonary specialist, board certified allergy and immunology. We've talked about chest pain, we've talked about acute coronary syndrome, about the real heart attack, we've talked about pulmonary emboli, we've talked about reflux disease, we've talked about other things that can cause chest pain, and we're about to talk about the sac around the heart, the pericardium. Tell me about the pericardium when it's causing chest pain. Why?
Sometimes it becomes deflamed for different reasons, but sometimes there's clues in the presentation. Now, I take chest pain clues with a grain of salt because there's those typical and atypical presentations. But in general, that's a pain that's worse when I lay down, better when I lay forward. There's not many other things you lean forward and hey, my chest pain is better. So that should be a clue that there's pericardial inflammation.
What's it sound like when you listen with the stethoscope with
we call it a rub, okay? So it has, and that's if there's lots of inflammation and depending on the acuity or the chronicity of the condition. But you can hear just a little bit of a friction rub. Oh, it's hard to describe it. Once you've heard it, you won't forget it.
Sort of noise.
That's pretty darn
that
good.
That was pretty good. So that's pericarditis. Is that a serious thing?
It can be serious because if there's inflammation, then all of a sudden there's fluid production, and this is a sac that's a closed compartment. So if that fluid builds up, that heart gets squeezed and squeezed and squeezed, then blood can't get into the heart. Well, if it's not coming in, it's not going out.
And so you start having symptoms of chest pain, shortness of breath, heart failure.
Yes, syncope, lightheaded, dizziness, those
Let's
things.
talk about something not so bad. Let's talk about what only big word I know, Tsetse syndrome, Tsetse, costochondritis. What does that mean?
That's an inflammation of the joints of the chest. A lot of people don't know that there are joints that articulate in the chest, but the ribs articulate with the breastbone, the sternum, and that can become inflamed. Now, Tsetse syndrome is a little interesting. It's usually one joint, and there's a lot of argument, is it a real thing or not, but certainly the pain is. And then costochondritis, usually more than one joint. But now it can act just like chest pain. I've seen it many times, and you'll miss it unless when you're listening to the heart, take the opportunity to push on the chest wall. You'll know immediately, patients quickly, that's it, that's the pain I'm having, and you'll know it's costochondritis.
So you're pushing on the rib cage. When you listen with a stethoscope, you can't move the heart, can you?
No.
So you're listening to the heart sounds, and here it's on the cartilage there, rib cartilage to sternum, and that gets inflamed, causes point tenderness or tenderness in the whole
Depends on
area.
which joints are involved. There's 2 or 3 of them, but yet it's definitely, you can have heart pain. I cannot reproduce that by exam. But costochondritis, I can push on your chest wall, and if you have costochondritis, you're going to let me know real quick.
The electrocardiogram, is that going to be normal or abnormal if there's costochondritis?
Well, it's going to be normal with costochondritis, but on the other hand, it may be normal with coronary problems too. But
So if it's within 6 feet, you got to think of a heart attack.
Absolutely.
I love that
Absolutely.
teaching point. Broken rib.
yeah, so pain
Can that
too.
cause chest pain?
Absolutely, okay.
What
And
type of pain?
Sometimes you don't even know you had a broken rib. I met many a patient have coughed for 4 to 6 weeks, cough, 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 and then they come in, boy, it hurts right here,
there.
okay. So it's usually with movement. It's usually maybe with a deep breath, those kind of things. But sometimes it's just a pain in there that you can't put a finger to, or you can't tell me where it's at, and I've got to go through that algorithm. Is it an acute coronary syndrome? If not, could it be an aortic dissection and pericardial tamp and all those things we've already talked about?
So you really got to be pulling a lot of possibilities. How about, you mentioned before we run out of time, tell me about how the gallbladder, the pancreas, you mentioned that earlier, how do they cause chest pain?
Yeah, so they were just under the diaphragm, and we think radiate to the shoulder, think of this abdominal pain, but sometimes it's just pain. And, we use the word pain, but to patients, maybe that's a squeeze or a pressure or just an uncomfortable situation. But definitely we always think gallbladder can radiate, pancreas can radiate into that. Usually there's other clues in the history, but always just keep a big, wide, open mind when you're thinking about discomfort in the chest. And don't forget the abdomen.
Don't forget the abdomen when somebody's having chest pain. So let's talk about a big medical word, pneumothorax. What's a pneumothorax and what kind of pain does it cause?
So pneumothorax, so the lung, it's millions of balloons, but think of it as a balloon. It can pop, okay? So some people have predispositions to that. Maybe I have underlying lung disease. Maybe I have COPD and emphysema. Maybe I have asthma. Maybe I have cystic fibrosis, which increases my risk of a pneumothorax. So that's a secondary pneumothorax.
How can you tell if the patient has a pneumothorax, a collapsed lung? Does it collapse the whole lung or just a little bit? Or?
Well, you can do all that, okay? But that's where your physical exam comes in. Usually be diminished or absent breath sounds on that side. X-ray, I mean, everybody with chest pain, get a chest X-ray and an EKG. A chest X-ray tells you all kinds of things.
What can it tell you about the heart and about pneumothorax? What is it?
Yeah.
What is it?
Well, if you're
Chest
having an
X-ray.
acute coronary syndrome, maybe you see evidence of right ventricular failure or pulmonary edema.
So the right ventricular failure, the right side of the heart, and you can see that it gets bigger and large. The chest gets, looks like there's fluid
Or
in
the
there.
right descending pulmonary artery may be enlarged too. So there's a lot of clues there. Other things on the chest X-ray you might notice, we always see them on our board exams, a little peripheral wedge-shaped infiltrate called Hampton's hump, and then there's Westermarck sign. You follow the blood vessels out, and all of a sudden they stop. Okay, those would be clues of pulmonary embolism. But pneumothorax is there's no markings, and the lung you can see the pleural lining and air.
So as you learn, you begin to get that differential diagnosis, and when somebody just has chest pain, you've got to go through a whole. One other thing that causes chest pain, what would you think of? We talk about a whole lot.
Yes, mediastinitis.
Now, mediastinitis, you said the heart is, the mediastinum is where?
Middle of the chest, lots of important organ systems there, but the esophagus is right there too. And so if we have a tear, a perforation of that esophagus, then we can get mediastinitis. But you can also get it from an abscessed tooth, dissects through the fascial planes to the mediastinum. So
a bad tooth can cause chest pain like that,
Absolutely.
and
So
a bad belly can cause chest pain like that, and a bad
Yes.
heart can cause chest pain, and collapsed lung can cause chest pain, and the cartilage can cause chest. How in the world do you figure it out?
Yeah, well, even the skin over the chest can cause it. So sometimes before we break out in a shingles or varicella zoster, you'll have pain with that.
That's right, and that would be the same.
Yet another thing to think
That's
about.
in a dermatome, so it could
Correct.
be in that segment of the skin that's right over the heart and cause chest
Yes.
pain. What's shingles pain like?
Shingles pain is a severe pain. If you've never had it, you don't want it. And not that that's our primary discussion today, but post-herpetic neuralgia, chronic pain.
Post-herpetic neuralgia, what does that mean?
That's pain in that nerve distribution, that nerve
It
domatoma.
stays around.
Stays around.
Yeah, and sometimes that's the fiercest of all.
Yes.
And that's why everybody should get their vaccination, the new one,
Correct.
Shingrix.
Yes.
If you haven't heard of it, you've heard it on the Dr. Bob Show. Shingrix, Shingrix, and that will won't keep you from getting shingles. It does 90% of the time, but it makes the pain less. Keep going.
Absolutely.
On chest pain.
How
How about the xiphoid?
Yeah.
What's that?
Yeah, xiphoid's a little process at the end of the sternum that can become inflamed. It's often reproducible too, though, if you push on that.
You know, a lot of people, they feel that little lump there and they wonder about
What
that
is
little lump.
that?
They keep pushing on it and it gets worse and worse and worse. And they say, that's tender. I must be having a heart attack. But that's not the case.
That is not, if you can push on it and reproduce the pain, that's not a heart attack.
So that's what you hope somebody has when they come to the emergency room.
Yes.
Well, you said sometimes the electrocardiogram doesn't even show it. Does it usually cause some abnormality?
Yes, usually does. There are significant changes that ER physicians and cardiologists
Emergency room physicians?
Yes, they become very attuned. What are those changes we need to look for? Definitely. I wanted to touch back on that pneumothorax. A pneumothorax can be just the deflation of the lung, uncomfortable, short of breath, a pressure, a funny feeling, you know something's not right. But it can be a tension pneumothorax.
That's very dangerous. What is that basically?
Tension is when that air enters that space and then continues to enter that space and starts to put pressure on the structures in the mediastinum. And again, of course, the heart's very important. It starts putting a squeeze on that. Blood can't return. And if blood's not coming into the heart, it can't go out.
What's the treatment for that?
That's relief of that pressure. A needle between the
Needle there,
ribs.
let the air out.
Yeah, absolutely. And that's immediately, you can see a blue face just come back to color just like that.
So you could talk all day on chest pain.
Oh, we could.
Yeah, but we've got to know that somebody has a crushing chest pain in the middle is to the emergency room quickly so they can reestablish flow.
Yes.
And no matter what kind of chest, if it's within 6 feet of the chest, you got to think heart and everything. Phil Jones, you're a great teacher. You know so much, and there's so much information to know that I want to thank you for letting people that are watching the Dr. Bob Show understand how difficult and complicated and how many things can cause chest pain.
I enjoyed it. Thank you.
Thank you for coming. Well, can you give me the differential diagnosis of chest pain? Know how important it is and that you get it evaluated. Chest pain means emergency room where it can be evaluated, especially if you know it's something that different. You'll know if it's there. Get to the emergency room quickly. Don't sit back and wait. And now if we've got time, we're going to be talking about a bulge in your belly that's due to a blood vessel. It's called abdominal aortic aneurysm and breast cancer. We know so much more about breast cancer, but we need to do better. You'll want to stay tuned. I want to thank Dr. Phil Jones. A wonderful discussion on chest pain. There are lots of things that can cause chest pain. Remember, if it's in 6 feet of the heart, you need to go to the emergency room, get it checked. Now, questions from you, the viewer, that I think will be important to your health. Question number 1. Dr. Bob, my doctor says I have a AAA. He says it's in my abdomen. He says it's an aneurysm. Could you tell me about it? Well, the aorta comes out of the heart, goes through the chest and down into the abdomen, the belly. From there, it sends blood down to the legs, or it goes to the kidney, or it goes to other organs. That blood vessel, the abdominal aorta, can get hardening of the arteries, and it can begin to balloon out. And you feel a pulsating in the abdomen. The doctor will get special x-rays, and he'll say you have an abdominal aortic aneurysm. If it bursts, you bleed to death. So what do you know what to do? Well, if it gets to be bigger than 5.5 centimeters or over 4 inches, or if it's enlarging rapidly, then they'll have to get it fixed. You can do that by some endovascular. You actually go into an artery, up into that artery in the abdomen, and put a slinky there. And that slinky will be endovascular correction of an abdominal aortic aneurysm. Or they can make a big incision and they can bypass it. Question number 2, Dr. Bob. What are some of the recent advances in breast cancer? Well, 200,000 new cases every year of breast cancer. It's very, very important that we find it early, just like it always has been in the past, because if you find it early, then the cure rate is 98%. So how do we find it early? Well, we recognize in the breast there are 3 basic areas to get cancer. The nipple area, the little brown area around the nipple called the areola. In the breast, there's fatty tissue, but there's ducts that go to lobules. So the lobules can have cancer. The tissue in the breast can get cancer, and the ducts can cause cancer. So all of those. So if you feel a little lump, if the nipple becomes inverted, it pulls toward the inside on one side, not the other. If you get bleeding from the nipple, if the breast is tender in one little area, or as it advances, sometimes one breast will be larger than the other, and there's an orange peel. Now, that's later on. When you find breast cancer early, it's usually with a mammogram. So be sure that you look at your family history. Be sure that you know if somebody in your family history has had breast cancer. Then start getting mammograms early. Know that there are some genetic tests, BRCA1, that's breast cancer A1, and A2. If there are some mutations of those protective genes, then you've got an increased risk of getting cancer. We can look at the breast cancer and we can see if it's receptive to estrogen or receptive to progesterone. That helps the doctor know how to treat it. Find it early. Can we prevent it? Well, we want to be sure and exercise, eat properly, stay healthy, and that will decrease the incidence of breast cancer. Get your mammograms. Watch and read and learn as much as you can. Men get breast cancer also, although it's much less than women. It's all the time that we have for this show. I wish we had hours and hours to talk about everything in health. But remember the 4 things that would be the best thing you can do. One is exercise. Be sure that you're exercising 20, 30 minutes, 5 days a week, hopefully 7 days a week. It can be just out walking. Get your tennis shoes, start walking a half a block, then a block, and get further and further. Reduces blood pressure, reduces stress, makes you feel good, makes you happy. It improves the health on the entire body and the heart. And if chest pain, it causes collateral circulation, new circulation around the heart. Be sure you're getting 7.5 hours sleep. If you're not sleeping well, talk to your doctor about why you're not sleeping. Know the importance of 8 hours of sleep. We're learning more and more about that. Eat properly. Eat fruit, fiber, smaller meals, less fried fatty foods. And most of all, what is it we like in the Dr. Bob Show? It's that laughter in your life. Know that when you laugh and when you're a giggle, your immune system works better. You'll stay healthier. You'll be happier. The people around you will be happier. And not only will you be happier, you'll be healthier.